Welcome back to Open School. Today's topic is what is Dejerine's aberrant pyramidal tract. I am Dr. Andrews, Professor of Medicine and consultant neurologist. This is a case-based discussion. Start with a patient. It's a history of a 42-year-old hypertensive man off medications for the last 1 year, presents with right-sided weakness, headache, dizziness, repeated episodes of vomiting, hiccups, and facial deviation, dysphagia, and hoarseness. So, here is a patient who has got right-sided weakness, facial deviation, recurrent episodes of vomiting, hiccup, hoarseness of voice, and difficulty to swallow. So, this is an acute onset problem. And any patient coming with a neurologic deficit, there are three questions. Where is the lesion? What is etiology? Is it part of some syndrome? And of course, you should say whether this is an organic problem or a functional problem. So, where is the problem? Otherwise called the localization. So, etiology will come at a later stage. So, it is an acute onset problem. So, the possibilities are: one is a vascular problem, second is a demyelination. Trauma is unlikely, epilepsy, migraine, etc. are the other causes that can present abruptly. So, considering the acute onset of weakness, we'll consider this as a vascular problem. So, the question in the vascular problem, is it a anterior circulation or posterior circulation? The patient has got weakness. Hemiplegia is classically seen in a cortical or subcortical problem. But the patient has got a dizziness, repeated vomiting, and hiccups. So, repeated vomiting can be due to raised endocrine tension. There is headache is there, but hiccups, dysphagia, and hoarseness suggest that the patient has got a involvement of lower cranial nerves. So, the stroke that classically presents with the hiccups is the medullary infarction. And patient has got a hoarseness of voice, and also there is a dysphagia, suggesting that he has got a involvement of the brainstem. And vertigo, if it is a true vertigo is there, again it is a more favoring. Here it is described as a dizziness. So here the important point here is the recurrent episodes of vomiting and hiccups. So let us look into how do vomiting and hiccups relate to brainstem. Vomiting is mediated by the area postremia in the dorsomedial medulla. Hiccups can result from irritation of the nucleus ambiguous. So, autonomic dysfunction in lateral medullary infarction includes hiccups and vomiting due to the involvement of the dorsal vagal complex. So, somebody comes with an acute onset problem, vertigo, vomiting definitely favors the brainstem. But hiccups is another important point that favors a medullary problem. So we can now localize the problem to brainstem probably. The lateral part of medulla because of the involvement of the 9th and 10th. So this is the lateral medulla, and this is the lateral medulla where the cranial nerves are, and the nucleus of the spinal tract of trigeminal, the sympathetic tract, the spinothalamic tract, etc. are situated there. You should be able to draw this picture and mark the structures. And here comes the pyramidal tract, and this is the sensory decussation. and this is the 12th nerve that is emerging out. So, what are the possible causes of sudden onset right-sided weakness with brainstem symptoms? So, we have already mentioned usually when you get hemiplegia, we consider a cortical problem. So, can brainstem lesion produce hemiparesis? Posterior septal stroke, especially brainstem infarction involved in the medulla and bones, can produce, of course, demyelinating illness and tumor can also present. So here we can see this is the medullary pyramid. Involvement of the medullary pyramid can produce hemiparesis. And the pyramidal tract that is affected in the bones can also produce a hemiplegia, but the pyramidal fibers are scattered. So usually pontine lesion produces brachial paresis, caudal paresis, etc. But of course, we can get a hemiparesis. And what is the percentage of stroke that is attributed to brainstem? 20% of the strokes are due to brainstem stroke. The brainstem, cerebellum, and occipital lobes are at risk in 20% of ischemic stroke that involves the posterior circulation. So we go into the clinical examination of this patient. On examination, he had right hemiparesis. Motor power is 3/5, increased DTR and Babinski sign. Left-sided Horner syndrome. So here you can see there is a meiosis, there is a partial ptosis, there is a left Horner syndrome, and had ataxia, left-sided cerebellar signs. Loss of pain and temperature, that is dissociative sensory loss on the left face and right side of the body. So he has got crossed findings. That is, on the left side of the face, he has got a sensory loss, and on the right side of the body, pain and temperature is low. So there is a crossing of findings. So this picture illustrates the, so see the left Horner syndrome. So now we're going to which granules and tracts are involved in this patient. Yes, got definitely involvement of the nucleus of the spinal tract trigeminal that is producing the facial dissociative sensory loss. Granular 9 and 10 are affected, that is producing the dysphagia and hoarseness. And the lateral spinothalamic tract is affected, that will explain the sensory loss on the contralateral side. So in the lateral medullary syndrome, the sympathetic fibers involvement leads on to Horner syndrome. And the inferior cerebellar peduncle involvement, the inferior cerebellar peduncle leads on to ataxia. The spinothalamic tract produces, here you can see the spinothalamic tract infarction of these leads because this fiber has crossed and reaching. So there will be on the contralateral side, opposite side you get a, and corticospinal lesion can occur if the infarct extent involve the pyramidal tract. And human facial palsy is there. Let me explain how we can explain, or how can a medullary lesion produce a facial palsy. So first of all, when there is a facial palsy, you have to differentiate whether it's an LMN or UMN. And you know how to differentiate LMN from UMN. The simplest way is upper half and lower half equally affected. That means it is LMN lesion. So that is a simple way. And here you can see that the patient has got a predominantly involved, the upper part is normal. So there is only mild deviation in the angle of mouth towards the right side. So this means patient has got a UMN type of facial palsy on the left side. So hope this point is clear. So the patient has got the Wrinkling is normal. Only thing is he has got a mild deviation of the face towards the right side, indicating patient has got a human facial palsy on the left side. So the question is, how can you explain this? To explain this, we to understand the brain pathway. So this is the corticospinal pathway or the coming down of the pyramidal tract, and normally it gives corticobulbar fibers to the bones. But sometimes the fibers can descend down into the medulla, cross over to the opposite side, ascend and supply the facial nerve nuclei. Suppose in a medullary infarction here, what will happen? The corticospinal fibers going to the facial nerve is affected. So what will you get? You will get a ipsilateral human type of facial palsy. In contrast to a brainstem lesion in the pons, that produces a LMN facial palsy with the cross-hemiplasia. Hope this explanation is clear to you. So what I have explained is the pyramidal tract or the corticobulbar fibers descend down into the medulla and then it ascends up and supply the facial nerve nuclei. And if this aberrant pathway is affected, that can produce a human type of facial palsy due to a medullary lesion ipsilaterally. Hope it is clear. So this one I will explain once more. This is the pyramidal tract. For the corticobulbar fibers, normally it gives off fiber supply to the opposite facial nerve nuclei. Instead, it descends down and then ascends upwards. And this pathway is called the aberrant path of Dejerine. It's a hypothetical pathway. Now we'll try to explain the crossed findings. Ipsilateral facial sensory loss. This is due to the involvement of the spinal tract or trigeminal. Contralateral dissociated sensory loss, that is pain temperature lost with the preserved touch. It is due to the involvement of the spinothalamic tract. Hope. And you should be able to draw the picture of the medulla and explain this. Now we go to the investigations of the patient. The patient had an MRI. MRI showed infarct in the lateral medulla. This is the medulla and there is an infarct. Left dorsolateral medullary infarct, and you can see the left side of vertebral artery is missing. So the vertebral artery is missing. So MRI shows absent left vertebral artery and pica or posterior inferior cerebellar artery. So this is a classical example of a medullary infarct, possibly due to vertebral artery occlusion. So now we'll go into how do vascular findings explain this. We should be remembering the circlovillis. This is the vertebral artery which join together to form the basilar artery, and this is the pica, posterior inferior cerebellar artery. And blockage of the vertebral artery more commonly or the pica, posterior inferior cerebellar artery, will produce infarction in this region. So here you can see this is again the vertebral artery joining together to form the basilar artery, and this is the pica, posterior inferior cerebellar artery. So this is the posterior inferior cerebellar artery. And this will produce infarction in the medulla, lateral part of the medulla. Hope this is clear to you. So this is the pica and infarction of the cerebellum, and part of the lateral medulla. So what is the final diagnosis? The final diagnosis, patient has got a left lateral medullary syndrome of Wallenberg with the contralateral hemiplegia and human type of facial palsy. So here again, this picture, you can see that this is the lateral part of medulla. And how will you explain the hemiplegia in this patient? If this infarction has affected the corticospinal fibers before crossing, because in the pyramids, the pyramidal tract, the pathways are crossing at the pyramid. If it is occurring here, what will happen? You will get a contralateral hemiplegia. So, hope this explanation is clear to you. So, today we have discussed the Dejerine's aberrant pyramidal tract. So, this is the corticospinal fibers or the corticobulbar fibers, a bilateral subpresentation of the patient normally. In some cases, it will descend down into the medulla and then ascends up and supply the facial nerve nuclei. Hope this explanation is clear to you. So, how does we differentiate pontine and medullary facial nerve? Last time we have discussed that the pontine, it is the LMS type of facial palsy. In medullary, it will be UMN type of facial palsy, usually ipsilateral. All of you should be able to draw this picture, try to learn this. And again, any patient with a stroke, look carefully for the Horner syndrome. And it is due to the involvement of the descending sympathetic tract. And remember, in medullary infarction, the pathway, that is the aberrant path of Dejerine, to explain the ipsilateral human type of facial palsy. So take home messages. Lateral medullary syndrome typically causes crossed sensory findings, Horner syndrome and ataxia. Contralateral hemiparesis and human facial palsy are typical, and we have explained it. Dejerine's tract is plausible explanation for facial findings. Prompt recognition and management are essential. Always correlate neuroanatomy with imaging and clinical signs.